This week's lecture will be looking at cardiovascular disease, but particularly conditions that are specific to cardiac rehabilitation. Just an overview on the lecture content. So we will be going through the incidence of cardiovascular disease, the etiology of coronary heart disease and coronary artery disease. So this is the first introduction of particular cardiovascular disease we'll be looking at. Then looking at the pathophysiology of CHD and CAD, the management of the two of these, then looking at a possible outcome from CAD, which is an MI or an acute myocardial infarction. We will then move on to look at chronic heart failure or congestive heart failure and having a look at the pathophysiology of that. Then moving on to the exercise prescription and special considerations for these populations. Firstly, let's define cardiovascular disease. So as you can see on this slide, I've split up the cardio and vascular components of the cardiovascular system. And the reason for that is because essentially cardiovascular disease is predominantly looking at the central system, which is the heart and the arteries and vessels surrounding the heart. So when we are looking at the peripheral system of the cardiovascular system, we are essentially looking at the arteries and vessels around the extremities, which is everywhere else except for the vessels around the heart itself. We already have a defined term for the condition or abnormalities at these sites, and this is called peripheral arterial disease and peripheral vascular disease, which we won't be looking at any detail in this lecture. So just to recap, cardiovascular disease is any form of abnormality or decrease in function of the cardiovascular system, which is predominantly talking about the heart and the arteries and vessels around the heart. We'll start off by looking at the incidence of cardiovascular disease. So according to the Australian Heart Foundation, cardiovascular disease was the leading cause of death in Australia in 2012. Based off these statistics, it kills 1 Australian every 12 minutes and affects 1 in 6 Australians. These statistics to you hopefully sound quite alarming. In a practical sense, what it means is when you do see patients or when you start to see clients, it's more than likely that you will see the majority of them who do have some form of cardiovascular disease. So cardiovascular disease isn't just a problem in Australia, it does affect the entire world, and it is the leading cause of death worldwide. As mentioned previously, so cardiovascular disease clearly isn't just a problem in Australia, it is the leading cause of death worldwide. But having a look at the split based off the World Health Organization data in 2012, ischemic heart disease and stroke, which are the two leading causes of death worldwide, over there with the blue bar and the purple bar, are both associated with cardiovascular disease. And as you can see, they are, in terms of numbers, well and truly ahead of your third and fourth leading causes, which are COPD and lower respiratory infections. So again, just really reinforcing how prevalent this disease is and how it really is having a huge impact on worldwide mortality. So looking back at the Australian statistics, so cardiovascular disease was the main cause for hospitalizations in 2011 to 2012. And lower socioeconomic groups were seen to have the highest rates of these as well as deaths. So within this group, we had Aboriginals and Torres Strait Islander individuals as well as those living in remote areas who had the highest rates of these. With coronary heart disease, it kills 55 Australians each day, as well as 1 Australian every 26 minutes dies due to this condition. So again, very, very alarming statistics, which is why, again, we need to start being aware of. Now, moving on to looking at a bit more detail with coronary artery disease and coronary heart disease. Coronary artery disease is looking at the atherosclerotic process. So initially, while there might not be some form of obstruction to the lumen, eventually in coronary artery disease, there is a blockage that then results in some form of obstruction of blood flow in the coronary arteries, which will eventually obstruct blood flow to the heart. And this, in essence, is a precursor to coronary heart disease. Now, unfortunately, in the health industry, coronary artery disease as well as coronary heart disease are used interchangeably. It is really important to define the fact that CAD actually is the precursor into CHD. So, coronary heart disease is really talking about the damage of the heart that has resulted from CAD. Generally, what we call this is ischemic heart disease, so a lack of oxygen going to the heart. So that's what ischemic means, so oxygen deprived. And essentially, what we can get as a result of this are certain symptoms or certain cardiac events that are arising, or a further progression onto another cardiac complication. So, a common symptom as a result of coronary heart disease is angina pectoris or chest pain. A cardiac event could be a myocardial infarction, which is a heart attack. We could have sudden cardiac death that occurs due to this ischemia that occurs around the heart. And then potentially as a result of this obstruction of blood flow, we can lead into chronic heart failure. The risk factors for coronary artery disease, and a lot of these should be familiar from your ESSA pre-screening tool, is cigarette smoking, dyslipidemia, hypertension, sedentary lifestyle, elevated glucose levels, including insulin resistance and obviously the diagnosis of diabetes, obesity. However, ones that we don't really cover in our ESSA pre-screening tool, so a high-fat diet, psychosocial disorders, some of those actually increase the risk of coronary artery disease. One you might not be as familiar with is an elevated level of plasma homeocysteine. Now, so this particular increase in homeocysteine in the blood actually has a person more prone to having endothelial damage or injury, which then can cause inflammation and promote the process of atheriogenesis. So this is particularly important when looking at the pathophysiology of coronary artery disease. If you're a male, you're at an increased risk, and age, so that's also in the ESSA pre-screening tool, but menopause as well. So once a female undergoes menopause, they lose that protective effect on the bodily systems from estrogen, and now as a result will be at an increased risk of coronary artery disease. Before we go into the pathogenesis behind atherosclerosis, let's firstly look at what a normal coronary artery is meant to be like. So this is defined as an artery with minimal or no plaque buildup within the artery or the arterial walls. So hopefully you remember from week 4 that we do have particular functional layers within the artery. So we have the endothelium itself, then the intima, media, and adventitia. The endothelium is the innermost layer of the arterial walls, and it essentially controls the passage of substances from the blood through the arterial wall. So we know that unless there is an injury to this site, the endothelium protects any sort of particles or foreign bodies entering to the other layers of the arterial wall. So the endothelium contains receptors for LDL, which is why when we do have an injury, we can actually attract the LDL to the site. And the endothelium, when it is healthy, produces vasoactive substances. So probably from exercise physiology, you might have heard of nitric oxide, which is your vasodilator or one of the vasoactive substances within your endothelium. Okay, and it is quite important to have the appearance of these vasoactive substances because it allows for the proper function of the arterial wall. And they also produce clot-dissolving substances, which again, if we do have a dysfunctional endothelium, is something that we don't want to become problematic, because this is when, again, we can have the arise of some form of cardiac event. So the next layer is the intima, which just lies outside the endothelium. Remembering back to the atherosclerotic process, so it is the basement membrane where atherosclerosis starts to form. So just outside of that is the media. So this is the area within the arterial wall that contains the smooth muscle cells, and it maintains the arterial tone because of these smooth muscles. And it should come to no surprise that the main function behind that is vasodilation and vasoconstriction. So the last functional layers that we'll be looking at, so we've got the adventitia, which lies just outside of the media, and it provides the media and the intima with the nutrients and oxygen that it needs. So while we didn't go into too much detail in Lab 4 about the internal external elastic membranes, remembering back that they are a part, or they are mentioned about in the atherosclerotic process, but essentially these membranes give the artery compliance. And this is really important because in order to have a nice healthy artery, we need them to have the ability to stretch, just due to the hemodynamics. We will now have a look at the pathophysiology behind atherosclerosis, so the precursors of CAD and CHD. But initially what we have is endothelial dysfunction, where there is an injury to this layer, which now allows for certain molecules to come through, namely LDL, which then in the next stage we have some form of inflammatory response. So you can see that there's monocyte infiltration, and once that occurs, while the monocytes then become macrophages, they can't really get rid of this LDL that is now oxidized within that layer. So then over time, what we have is this fatty core buildup, which may or may not affect any form of blood flow through the lumen itself. And unfortunately, if this fatty core does come in contact with the blood, we do have a thrombus that occurs, or clotting. So we will have a look at these stages in a little bit more detail over. Now let's translate that summary into an overview of the pathophysiology behind atherosclerosis. So initially in atherosclerosis, we have a buildup of LDL, which is build up in the blood itself. So we now have greater circulating levels of that. And because we now have a dysfunctional endothelial wall, which could be caused by high blood pressure, so that wear and tear on the actual arterial wall itself, we can have cigarette smoking chemicals, which actually affect the function of the endothelial layer. And don't forget if somebody has elevated homeocysteine levels, so that actually predisposes them to actual damage of the endothelial layer. So as I was saying, because of that damage now to the endothelial layer, we have that injury. So now we can have these LDL molecules to surpass the endothelium. So once that happens, the LDL will go into the intima and oxidize. Because there's now a foreign body within the intima and the human body will react to having that there, it will have white blood cells migrate to the site of injury. Once monocytes enter into the intimal layer, they then become macrophages. And these macrophages want to eat up and take away the oxidized LDL and dispose of it. But unfortunately, in the atherosclerotic process, once macrophages try to get rid of oxidized LDL, they become foam cells. And these foam cells can't go past the endothelial layer, so they just hang around the intimal layer. And unfortunately, over time, these cells die and release their lipid content. Now, because of this inflammatory response, an attempt of healing over the actual injury site then happens. So a thin fibrous cap of collagen and elastin fibers then forms over the top. Unfortunately, because this cap is so thin, it still makes the lipid content itself very vulnerable to rupture. So over time, there is this accumulation of the lipid in the intima itself, which has an effect on the elastic membrane. So remember that the intima has an internal elastic membrane. So what we call this is arterial modeling, where this elastic membrane now stretches to compensate for the lipid that is now entering into the intima, so that there isn't any effect to the lumen the lumen circumference itself. So we have normal blood flow. Unfortunately, because of this arterial modeling, we can't really detect it with the majority of screening tools that we have at looking at the actual circumference of the lumen itself and seeing if anything is indicative of atherosclerosis. However, if there is rupture to this plaque, then this lipid core then comes in contact with the blood. So this is essentially how we get a clot. So a thrombus can then form, and then we could potentially have some form of cardiac event occurring, or this clot could travel from one part of the body to another. If this happens, if an event doesn't occur as a result of the embolus or the thrombus that is now potentially going around in the body, what will then happen is an attempt of healing over the injury site again. The positive that comes out of this healing over is that the lesion itself will now have a higher fibrotic content, which means that it's less likely to rupture because it's stronger with that fibrotic content. And this is indicative of a progression in atherosclerosis or atherogenesis. You have the YouTube video there as a reference point to go back again to have a look at the pathophysiology behind that. And if you're a visual learner, this may help that. But you do have a summarized version here in your notes. So if you have any questions on this section, you can give me an email. But for now, have a bit of a brain break before you go on to part 2 for this lecture.